Good afternoon, everyone. Good afternoon. Welcome to the 6th Annual Food is Medicine Symposium. My name is Robert Greenwald. I'm a clinical professor of law here at Harvard Law School and the faculty director of the Center for Health Law and Policy Innovation here at the law school. CHILPI, the Center for Health Law and Policy Innovation, houses both the health law and policy clinics here at Harvard Law School, and our mission is to engage in state and national research, policy development, and advocacy to promote more equitable and effective healthcare systems. Since 2011, we've had the pleasure of being law and policy consultants to the Food is Medicine Coalition, a national network of nonprofits across the country who provide medically tailored meals to people with serious illness. More recently, we've had the privilege of working with Feeding America and many of its food banks, as well as many other nutrition and service providers. In addition to Food is Medicine, CHILPI is currently working on a broad range of initiatives at the intersection of food and health, including initiatives to reduce sugar consumption, to reform physician education to include a more robust nutrition curriculum, and to reshape the Farm Bill to support SNAP and other food and nutrition service programs, as well as a more sustainable food system. As you will hear a bit later in the program, along with community servings, we're also leading an effort to develop a first-in-the-nation Food is Medicine state plan here in Massachusetts. We're thrilled to co-host this event today with Community Servings and our great friends and colleagues, David Waters, the CEO of Community Servings, Jean Terranova, the Food and Health Policy Director at Community Servings. For those of you who are not familiar with Community Servings, it's an organization that serves medically tailored meals and nutrition education to thousands of people across the Commonwealth, all of whom are unable to shop or cook for themselves and their families due to serious illness. Community Servings has come a long way since its inception in 1990, when a coalition of AIDS activists, faith groups, and community-based organizations all came together to feed about 30 individuals struggling with AIDS in the Boston area. This past year, Community Servings prepared and delivered its 7 millionth medically tailored meal here in the Commonwealth, and I think that in itself deserves a round of applause. It is truly incredible that over 400 people registered for this event today, and that we had to close registration last week because we were at maximum capacity in this room. Frankly, it wasn't that long ago when we hosted this event and there were 50 people in the room, and the most common questions we were receiving were questions like, what is food is medicine? And then specifically to me, why do lawyers care about food? Well, times have certainly changed. Last week over breakfast, I read the experts blog in the Wall Street Journal. It was titled, "In the Battle Over Healthcare Costs, Food Can Be a Weapon." I was thrilled to see that research on food is medicine, in particular medically tailored meals that had been produced by Community Servings and other colleagues in Colorado and Pennsylvania, were both recognized in this article. And my first thought on reading the article was, this is truly awesome. The Wall Street Journal, not necessarily known for its health and food reporting, was now publishing blogs that really talk about the important role that food can play, and that food being integrated into public-private health insurance systems can really make a difference in people's lives. Ultimately, the article really recognized that food is medicine meets the triple aim of healthcare reforms. It improves health outcomes, it increases patient satisfaction with the healthcare system, and it reduces costs. The article really came on the heels of just a broad range of articles over this past year about food as medicine, including a wide range of the kinds of interventions that fit within this idea of a food intervention, from medically tailored meals to food boxes that are designed for specific health conditions, to fruit and vegetable prescription programs that help to address food insecurity and malnutrition. This really made me wonder, are people getting the connection that all of these interventions are part of the food is medicine intervention, if you will? Now, the night before reading the Wall Street Journal article, I was reading a Kaiser Family Foundation poll, and this poll was about expanding access to health care to all Americans. The poll showed that 62% of Americans are in support of Medicare for all. 61% support universal health care coverage. 56% a national health plan. 48% a single-payer health system, and 44% socialized medicine. This concerned me, as they're all part of the same fix, right? Medicare for all is universal coverage. It is a national plan. It is a single-payer health care system, and ultimately, it is socialized medicine. So the poll really made me start to think about how important it is that we clearly define what we are talking about when we mention the term food as medicine. And I think it's important, particularly if we're going to try to have a movement that really moves the agenda of food as medicine forward. And so here is what Chilpi has in mind when we define the term food as medicine. To Chilpi, the definition of food as medicine is a food and nutrition service that is accessed through the healthcare system or is delivered in collaboration with a healthcare provider that improves health outcomes and helps to bend the cost curve. Clearly not a great soundbite. We'll work on the sort of pithy one-liner. But we basically recognize that there's a broad continuum of interventions, if I can get there, that fit within this concept of food as medicine, across a continuum or a pyramid, if you will, of prevention and treatment interventions. Each of the interventions shown on this slide is food as medicine, and to varying degrees and in varying ways, they meet the triple aim of health reforms. Similarly, the providers of each of these kinds of interventions have been working and are successfully building an evidence base as to the effectiveness of all of these interventions. So we are making progress, and food as medicine interventions throughout the pyramid are being prescribed by providers and being paid for by insurers. They're improving health outcomes and they're bending the cost curve. So as to the question, why are we as lawyers engaged in this food as medicine movement? We have some legal analysis and drafting skills, and those have turned out to be quite necessary when it comes to trying to integrate food as medicine into healthcare financing and delivery reforms. Together with food as medicine, food and nutrition service providers, we're increasingly identifying public and private health insurance laws, regulations, and policies that need reform. And we're accomplishing these reforms, and in doing so, we're integrating food as medicine into public and private health insurance systems, and again, driving triple aim success. So we are really proud to be part of this effort that's working together with community-based health and social service providers, health payers, and governments to transform our healthcare system. And so I thank you all for being here today, for participating in this symposium, and to whatever extent you're involved to help drive this food as medicine movement forward. And so I know I'm kind of preaching to the choir here, but I just have to say, having so many people here and so many people increasingly engaged in food as medicine, we just have to think that one day we'll be successful at changing the promise of food as medicine into a reality for all people who could benefit from this intervention. So as to the agenda, today I have to say we have a really packed agenda, so we're going to try to move through it quickly. And let me say, we're going to start with the Food as Medicine State Plan Initiative. And as I mentioned, my center, Chilpi and Community Servings, along with major stakeholders across the state, have recently completed the research phase of a comprehensive effort to assess the need for and access to food as medicine interventions here in the Commonwealth. And tonight, Sarah and Jean, the leaders really of this effort, are really going to describe some of the research findings that we have uncovered over the past year. Next, we're going to hear from Dr. Seth Berkowitz, a physician and renowned researcher on food as medicine, who's going to really talk about the research that has been accomplished, as well as what additional research is needed to really help us further integrate food as medicine into our healthcare systems. We're then going to have a brief but very exciting update about a statewide project that's taking place in California, really a watershed moment for the food as medicine movement, the largest scale initiative to date to integrate medically tailored meals into the Medicaid program. Then we're going to return to Massachusetts, and we're going to hear from 3 physicians who are basically going to describe their perspectives on the role of food as medicine, as well as the role that their institutions can play or should be playing in integrating food as medicine into our healthcare system. And then finally, we'll have the opportunity to ask questions, and then David Waters, the CEO of Community Servings, is going to close out the agenda. So one more time, I just want to thank you all for being here. Welcome to the 6th Annual Symposium, and I'm going to turn it over to Sarah and Jean.
Thanks, Robert, and thank you all so much for coming tonight. It is so exciting to see so many of you here. The way that we are going to break this down in introducing the work of the Food as Medicine State Plan is I will give you some background on why Community Servings has gotten involved in this and who the stakeholders are in the project, what the goals are, and Sarah then gets to do the hard part and break down what we have found preliminarily in this project. And we launched this about 12 months ago, and we are really also thankful for the DentaQuest Foundation as well as the Blue Cross Blue Shield of Massachusetts Foundation for their generous support of this work. So Robert, you've seen this slide. Robert showed it earlier. This is what we call the Continuum of Food as Medicine Interventions. But before we kind of get into the details of what these interventions are and what specifically Massachusetts organizations are working on along this continuum, I just want to back up and explain why Community Servings, a not-for-profit, medically tailored meals provider, is kind of moving outside, seemingly moving outside of its lane and getting involved in an initiative like this. And the reason why, kind of generally, the big picture reason is that we believe that access to the entire continuum of these services should be embedded in the fundamental right to health care for all in this state. And this right to health care for all is one that Massachusetts has been a pioneer in recognizing. And so with that frame, we really believe that there is an opportunity here to embed these services into healthcare services for people who are dealing with poverty and chronic illnesses. So just to start at the top of the continuum, because that, and also, I just want to also say about this, is that I think that we tend to silo these services to think that someone might need a medically tailored meal and that's it. And then we provide a medically tailored meal and they're all better and they don't need anything anymore. And as we know from just dealing with human beings, that is not the case. There could very well be a person who needs all of these services at one point in the cycle of their care. So we want to make sure that at Community Servings, even though our expertise and what we have been doing for 29 years is providing medically tailored meals to people who are chronically ill, who are really the sickest of the sick in the Commonwealth, we need to partner because we know that if we do what we hope to do and help these people transition off the service, manage their care, they very well may need another medically tailored nutrition service, and we want to make sure that those services are there for everybody who needs them. So Robert gave us a great legal definition, which we all loved, of medically tailored meals. But as a practical matter, in terms of the service that we provide, these meals are designed by a registered dietitian nutritionist to address complex medical and nutritional needs of the highest needs, highest cost individuals in the state. The meals are designed to address chronic illnesses, co-occurring illnesses, and medication side effects. And we provide at community servings 5 days worth of these meals, and they're delivered weekly. And so again, this is not 100% nutrition, and so we know that our clients who need other resources should be able to have these services outside of the medically tailored meal. And then in the next, I'm sorry, and then the other issue with respect to our service is that we don't reach the entire state of Massachusetts, and so we know that we need to form partnerships to serve people who need these services in, for example, Cape Cod and the Berkshires. And then finally, we feel that banding together with other nutrition service providers across the Commonwealth gives us a much larger voice in advocacy. And then the second tier of this continuum, medically tailored food for people with acute or chronic illnesses. And our friends from Just Roots are here today, which is a farm in western Massachusetts. They're providing farm share packages to chronically ill individuals, which are referred through a community health center of Franklin County. So that's an example of that second tier service. And another example is the gluten-free food bank in central Massachusetts, which tailors its services to people coping with celiac disease. And then third, and so, those first two we really consider to be treating people with chronic illnesses through medically tailored nutrition. And then on the prevention side of the continuum, these are less intensive, less costly services that are intended to reach more people. And so, for example, you might have medically tailored food for people at risk for acute or chronic illness, such as the Flavor X program on Cape Cod, which you'll hear about with our third panel. And then at the base, you have healthy food for those who are malnourished or food insecure. And an example of that is Fresh Truck, which brings mobile healthy grocery to communities with high rates of food insecurity. And then a program by the Greater Boston Food Bank provides technical assistance to community health centers to screen for food insecurity, and they periodically provide healthy pantry programs to the community health centers where there is a high prevalence of food insecurity. And then I just want to say one word about what you might think is missing from this pyramid, which are other very important social determinants of health interventions, including non-tailored anti-hunger interventions, housing, education, employment services, transportation services. And we recognize that these are incredibly important to holistically address the health of people in the health system who are coping with complex illnesses and poverty. But we, for the purposes of this project and plan, we're focusing on the food as medicine interventions, primarily because this is our field of expertise. There's a growing body of evidence, as you'll hear from Dr. Berkowitz, demonstrating the efficacy of the services. And we want to seize on a moment of transformation in the Massachusetts healthcare system that seems really ready to integrate these services. So why in Massachusetts and why now? Well, you might have read the report that was produced last year by Children's Health Watch and the Greater Boston Food Bank, estimating health-related cost of food insecurity and hunger in Massachusetts to be $2.4 billion annually. And there is also this growing body of research, which you will hear about from Dr. Berkowitz, demonstrating the cost savings to the healthcare system for these interventions. And these are gaining attention, as you heard, in Massachusetts, but also nationally. Robert Greenwald referred to the Wall Street Journal blog post, but there has also been reports in the Washington Post, the New York Times, the Los Angeles Times, the Boston Globe, and Health Affairs. So it's really gaining traction. And now just to touch on the objectives of the state plan. First, we have conducted an environmental scan of what food as medicine interventions currently exist in Massachusetts, and what is the desire and the capacity of non-food as medicine community-based organizations to provide these interventions. We're identifying the need for food as medicine interventions in communities that are not currently being served, and we're developing a strategy to increase the availability of food as medicine interventions to meet the level of need throughout the state. And who has been involved in this process? Who are our stakeholders that have been at the table helping to direct this work? We have an incredible 34-member planning council, which consists of a cross-disciplinary group of healthcare payers and providers, policy leaders, community-based organizations, philanthropy, and academic institutions. They represent every region in the state, and they have a special ribbon. So if you see somebody with a planning council ribbon, thank them for their work. Sarah.
All right, thank you, Jean. So I want to say, before I go into the data, I just want to say that this is a very rare event at Harvard because there are people in this room that come from every single region of the state of Massachusetts. And for Harvard, that's rare. We're not in a university that does a lot of state work. And certainly that's a first for this event here at the law school, and we're very proud of that. I think that really underscores Jean's point that this is a food as medicine moment that we're having here, and also the power and reach of our planning council. And they have really been a huge part of helping us make effective connections and genuine connections across the state and across all of our stakeholder groups. So we're very grateful to them. So step one of our food as medicine state plan was pulling that planning council together. Step two is gathering the data that we need to demonstrate the need for food as medicine services here in the state. So I'm going to talk now about what we now know as a result of our data gathering process and how we know it. So first, we wanted to get a full picture of where the food as medicine interventions were available in the state. So Jean and Robert showed you our food as medicine pyramid and described how we think about these interventions. For the purposes of the surveys that we did, we wanted to know where the following interventions were available. So those medically tailored meals that we've talked about a lot today, the meals designed in consultation with a dietitian, tailored to someone's health condition. Medically tailored food boxes or packages, so those are the component parts of a meal, a full meal, still designed to be tailored to someone's health condition, still designed in consultation with a dietitian. Or fruit and vegetable prescription program or voucher program, right? So produce or community-supported agriculture programs prescribed by a healthcare provider, or a general healthy food access program that's meant to respond to food insecurity, offers healthy food as a response, and does so in collaboration with some kind of healthcare partner. So to figure this out, we did a series of surveys. So we asked community-based food and nutrition service organizations if they provided these services and where and how often. We asked health insurers if they pay for these services or use their care coordinators to connect patients to these services. We asked healthcare providers if they either provide these services within their institutions themselves or refer patients outside to community-based organizations to receive them. And we asked how they identify these patients. So do they screen for food insecurity, for example? We also asked each of these groups about their perceptions of food as medicine interventions, of the importance of these services to individual health and their patient populations, the barriers they faced when they want to do more, and the opportunities that they saw to transform the healthcare system to include these services. And then to round out that picture and really build out the multi-sector relationship infrastructure within the state, we held a series of regional listening sessions to confirm and flesh out the information that we were getting from the surveys. So this was critical. It really helped us understand, what are the universal issues across the state and what is specific to each region. And then in addition to those listening sessions, we hosted 3 others that were tailored to physicians and clinicians, one to oral health advocates in particular, and we solicited written feedback from other groups as well. We also heard from our planning council early on, and of course we certainly agreed with this point, that it was critical to bring the voice of those who actually received and used these services into this initiative. So we were able to do in-depth interviews with about a dozen individuals from across the state. And finally, we gathered data from all of our public sources with the help of our State Department of Public Health and Department of Public Transportation, and from our partners at Feeding America and Project Bread, to be able to map the rates of chronic disease and food insecurity and transportation challenges, so that what we can begin to do as a result of this is hotspot the areas where there is a high likelihood of the need for food as medicine interventions, and you'll be able to see the results of that in just a minute. So that's what we did. What did we learn? So from providers, we learned that there is a perceived lack of knowledge about the relationship between food and health. Many providers were willing to openly admit that they did not know as much as they felt they needed to know. They did not feel their colleagues knew as much as they needed to know, and that they articulated very clearly to us that if we were going to get providers as a group to screen routinely for food insecurity in the healthcare setting, the screening had to be simple, take very little or no time to do, be embedded into the patient's electronic medical record, and result in an easy-to-follow path for the provider to connect the patient to a service that would be responsive to that patient's need. Very few institutions that responded to our survey identified as screening for food insecurity on a consistent basis. Even fewer were tracking the results of their screening. People recognized vaguely that this might change with the advent of the Mass Health requirements. So Mass Health is now going to require its ACOs to screen for health-related social needs. But even those who were going to have to roll out screening programs very soon were not doing it yet, by and large, and did not know how they were going to do it. What about our payer community? So when we did outreach for our insurers, we invited everyone who operates in our state to participate, but in particular, we really tried to get feedback from those who are serving Mass Health members or other Mass residents who are low income, so those who administer our connector care plans here in the state. The chart here in the slide is hard to see, it's very small, but what is important about this is the two bars on either end that are in equal height, and they represent the number of plans that say they are paying for medically tailored meals, that's on one side, and the number of plans that say they are not paying for any of these services at all on the other side. And so while medically tailored meals are making some inroads, I think, in our payer community, the vast majority of our payers are not paying for anything at all. And I think one of the most interesting things about the food as medicine insurer data is that although everyone basically agreed that these services are really beneficial to patients, they benefit the mission of these organizations and companies, they have no plans to expand coverage of these services. And to me, this points to the need to use law and policy reform to give them the flexibility and space and security and incentives to innovate and experiment with expanded coverage. Our third major line of investigation was CBOs, community-based organizations within the state. So what food as medicine services were they providing, if any? If they weren't, did they want to, and what was stopping them? Again, this chart is very small. I'm going to draw your attention to the two tallest bars to make my point here. The tallest bar represents the number of CBOs who responded and took our survey and do not provide any food as medicine interventions at all. They provide some kind of food and nutrition service within their community, but none of the things that I mentioned. The second tallest bar represents organizations that are doing something in collaboration with a healthcare partner that is a general healthy food. They're generally offering healthy food to folks who are food insecure. So what we see here is a real lack of access to medically tailored food and nutrition services, which will be underscored as a problem by the spatial analysis and mapping that we did of chronic disease, which you'll see in just a minute. And as excited as we were to learn about every new program that was doing something new and creative with respect to providing food as medicine interventions, we were really just as excited to have engaged CBOs who are telling us, we don't do this yet, but we want to, because this is a whole infrastructure that we already have in place that we can build on to scale up access of these services. And of course, the number one CBO challenge is funding. This does not surprise anyone in this room, I'm sure. Funding is temporary. Funding is vulnerable to downturns in charitable giving. You create a grant program. You create a new program with grant funding, but you generally can't double down on a program with grant funding. You generally can't scale a program with grant funding. So CBOs want to partner with healthcare. They want to offer healthier services and medically tailored services, but they need the resources to do it and the technical assistance to be able to achieve that. And then, of course, across the board, everyone cited, from providers to insurers to CBOs, cited the need for leadership to be fully engaged in this concept and supportive of everyone doing the work to make sure that we transform our system. They also acknowledge the need for tools to communicate across these sectors and increasingly tools to just communicate about what's going on within their own institutions. And perhaps that challenge is really best illustrated by some information that came out of our regional listening sessions. You can see a couple of the pieces of that feedback that came out of those sessions here on the board, but I'll just tell one story. So we had small group breakouts at these listening sessions, and at one table we had someone explaining, the way we respond to someone who has food needs, a patient who has food needs, is there's a couple of laminated lists of about 10 pantries that float around the office, and the person goes and finds that list, wherever it might be living at the time, and they look at it and they give the patient the appropriate number to call. And then we had someone at another table who was saying, we're really excited. We just rolled out this really sophisticated, HIPAA-compliant e-referral platform where our institution can share information with the CBO, and the CBO can tell us information back about whether the patient got the service. And those people worked at the same institution, right? So, there is challenges even within institutions about what is going on in this area. And even though people believe in this work and they believe in the mission and they believe in the value, there are doors that are still closed to them. And so we need to figure out how we open up those doors. As we noted earlier, bringing in the voice of the people who receive some of these services was really, really important to us. And what we saw, first of all, was that folks felt like these services were addressing hunger. Hunger was a reality for many of our interviewees, and the value of these services for that alone is very important, of course. However, what's really interesting is that these folks did understand to a large extent and were able to, without prompting, tell us specifically how the food was making them healthier. So without being asked, did this happen, did this happen, did this happen, we heard specifically lower blood pressure, weight loss, lower A1C, lower cholesterol, improved breathing, lower need for medication, all from these interviews. And the other thing that we can't, of course, undervalue is that they really valued the sense of community connection that receiving the service gave them. They felt like someone cared about them, and it felt good to receive the service. All right, so through this Food as Medicine State Plan initiative, we've built a new body of data that we're still mining and we're still analyzing, and it's telling us a lot of new and really, really interesting stories. And we want to be able to layer on top of this data, or layer this new data on top of food insecurity rates and on top of chronic disease burden in particular, so that we can say, if there's a food as medicine need for interventions here in the state and there's nothing there, let's make it a point to direct resources there. Or if there's something here but it's small in scale, how do we scale it up? So it was clear that we needed to do some mapping, and here's how we did it. We used a number of different data points, and we created an algorithm to identify what we're calling food as medicine high priority areas. So in these locations, there's a high level of food insecurity, according to Feeding America's Map the Meal Gap data. There's also a high chronic disease burden, and to assess that, we got information about rates of chronic disease associated with food insecurity across the state, rates of certain types of cancer, and rates of acute episodes related to diet-related illnesses, so hospitalizations primarily for cardiovascular disease and things like that. We also looked at vehicle access because that came up repeatedly as a factor contributing to food insecurity in every regional listening session, even the one in Boston. This was a rural problem and an urban problem, and we could not ignore it based on the level of feedback that we had about that. So we combine these to identify where the need for medicine interventions is likely most acute. And you can see those identified in the darkest blue areas here on the map. And we don't have time today to fully show you how we can cut and visualize all this data that we gathered and layer it on these maps. So I'm just going to run really quickly through a couple of examples of what we're now able to do because we've been engaged in this work with our planning council and all of our stakeholders and have all this exciting new information. So on top of this food as medicine priority area map, we can now layer the locations of every emergency food provider in the state on this map. So this is thanks to publicly available data from Project Bread. But then what we can do also is we can show you just how many of these folks drop right off the map when you consider only those who provide a food as medicine service. And we can show you where those organizations simply do not exist as far as we know. We can further break down these organizations by type. So you can see that even though an area might have a food as medicine provider, maybe they're only doing a produce prescription program, which is great and critical, and we should have those in every area of our state, but it's not going to meet the needs of someone who needs a medically tailored meal. We're able to also show you the service areas of certain food as medicine interventions. So this slide is just an example of service area of community-based medically tailored meal providers here in the state. And you can see that a number of our priority towns, particularly in Berkshire County and the Cape, don't fall within this green area up here. And when you look at the service areas for the other food as medicine interventions that we're able to map, the service areas really only shrink. And finally, what we're going to be able to do at the end of the day is we're going to be able to zoom in on each region of the state to give policymakers a really full picture of what the landscape looks like and where the urgency for action and opportunity is the greatest. So we broke out the Cape here, and all this data is not, you need to worry exactly about what this says, but you can see the kind of information that we're going to be able to take to policymakers and say, take a look at your region, take a look at what's going on here. Here is some case studies, here's some opportunities to scale, some innovators in your area, some challenges that are specific to your region. Let's tailor our solutions accordingly. And so, once again, these slides and these maps will be available, and this data will be presented at like much greater length and with much more depth in a variety of ways across the fall and winter. But where do we go from here? And the answer is really that we go right back to our planning council and we put them to work and we identify all of the concrete actions and steps that respond to the picture that we've painted for you here tonight. So we know that the system that we're pushing towards is one with knowledgeable providers who routinely recognize when their patient has a nutrition need in the healthcare setting and track that information, that they are referring or having someone on their care team then refer the patient to an appropriately responsive intervention with a warm handoff and ideally some way to figure out whether the patient has connected to that service so that they can think about changes to that patient's health profile in light of that connection. And then finally, where every patient who is referred has a high quality and appropriate service available in their community because these services are adequately supported. And that's either through insurance or through the provider institution itself or through some other type of infrastructure that sits on top of all of the things that govern our healthcare system. So the Food as Medicine State Plan is really going to identify those concrete and specific steps that we can take as a group within our state to realize this system. And so, we really look forward to engaging our planning council and you all in this work in the months to come as we create this state plan. And we look forward to working in partnership with you to implement the plan following its release in the spring of 2019. So we're going to hold all of the questions tonight until the very end of the event. But I just want to give you a big thank you for being part of our journey so far. And now I'm going to introduce Dr. Seth Berkowitz, who's going to help us understand the state of the current research into food as medicine interventions.
Well, thanks very much. It's certainly very exciting to see how this event has grown. Even I don't think I was at the first, but it was a relatively early adopter, and it's been very heartening. And I really feel like this is a topic that's at the really the forefront of a lot of people's energy right now, and so it's exciting to see. I have no conflicts to disclose for any of these research papers. So I think this won't come as a surprise to anyone, but so it's well known that hunger worsens health, and that this in turn will often lead to higher healthcare utilization, and that leads to higher healthcare expenditures. The question is, what do we do about it? And we've heard about some of the interventions that have some evidence behind them, but overall, this question of what to do is not as simple as it seems. The good news is that we've seen a substantial increase in research about interventional programs for food insecurity and in the food as medicine space, particularly over the last 5 years, really building on work over the last 10 to 15 years. However, these interventions vary quite a bit in their intensity, which can take many factors. Intensity could be the amount of resources you put into the intervention, the cost, the amount of time that someone is spending with the recipient of the intervention, the sort of number of FTEs you need or something like that. They vary quite a bit in the population that they're used in, people with certain types of illnesses, different ages, different mobility restrictions, et cetera. And all of these combine to really mean that there can be wide variations in cost, or to put it another way, the number of people that you can serve with the same amount of money. I'm going to talk about some of the different types of approaches and just some of the evidence behind them, and then ultimately I want to wind up by trying to put this into an overall framework of thinking about where to go next as we're determining what are effective interventions. So I think for most people, although this isn't necessarily always the food as medicine model, I think the most common type of social determinants model of intervention in the healthcare space right now is what I think of as a linkage intervention. So usually health-related social needs like food insecurity or housing instability or something are identified in clinical care. And then people are linked to community resources, generally ones that already exist, not created as part of the program, to help meet these needs. So you can imagine screening for food insecurity and then linkage to help people sign up for the SNAP program or participate in a local community food pantry or something like that. From a healthcare system perspective, these are often viewed as less expensive because though there's the cost of the screening and the linkage, the actual intervention itself is not paid for by the healthcare system. And so that's a major plus. Also because the amount of interaction with the person is relatively limited, usually a brief screening, an intake interview, and then the navigation. The number of people who can be served per FTE or whatever full-time employee's time or whatever unit you want to use is relatively high compared with other things. So that's attractive as well. The downside is the resources may be limited, so this relies critically on having an existing resource that meets the particular need of the individual, and as we saw in many areas, that's not the case. It also tends to require a relatively high level of recipient engagement because not a lot of support is being required. So, for example, a person may have to go to the food pantry, pick up the food, bring the food home, prepare it in a healthy manner, et cetera. So that's just to describe this type of intervention. These types of interventions do have some evidence of their effect on health, with sort of the pictures of 2 studies just as examples there that show that. So they're useful in that sense, but have a number of considerations number of things to consider when using them. Another sort of type of intervention sort of falls in the education realm. So an example of this is the SNAP Ed program. These types of education programs really focus on helping people use the resources they have better or in a way that may promote health more than would be done in the absence of the program. So SNAP Ed sort of specifically focuses on helping people eat healthy meals on a budget and sort of ties into the types of benefits that people get with SNAP and sort of using those SNAP resources well. Again, this can be a relatively cost-effective intervention and can reach a relatively large number of people per sort of unit of cost. However, it may be the case that even with that, the education is not the issue. It may truly be lack of resources. If you simply don't have enough money to buy healthy foods, even if you know what foods you should be buying or how you should be preparing them, then it may not be fully effective. This also can require a fairly high level of engagement. People come to the programs, incorporate the information, learn it, use it in their own life, and so that may not be successful for some subsets of the population. Third type of program I think of as resource supplementation. So this sort of takes an existing resource and builds on it to some extent. So a great example of this from Massachusetts is the Healthy Incentives Pilot that many of you are familiar with. This provided a subsidy for fruit and vegetable purchases at local farmers markets, often in conjunction with the SNAP program. This was proven in a randomized evaluation to be effective in increasing fruit and vegetable consumption, the healthfulness of people's diet, which is a great thing. This will often be a little bit more expensive than some of the other types of programs I've mentioned because you're actually putting additional resources in to help people eat healthier. That it may well be good value for money, so I'm not saying it's too expensive, but it often is sort of in the moderate in expense. Sometimes, though, for some people, the amount of supplementation may not be fully sufficient to allow them to eat their needs. And again, this is something that can require a fair amount of engagement for people to go out, shop, et cetera. The last type of intervention I want to talk about in this food space is the medically tailored meals, which I think we're all fairly familiar with at this point. These on a per person basis are often relatively higher cost. You're providing a fair amount of food for people over the course of the month. Again, they still may represent good value, good use of the resources, and in fact, some evidence has suggested that they can even be cost savings from an overall system perspective. But the individual amount of benefit is often relatively high. Unlike sort of solely relying on existing programs, you have a lot of flexibility here to carefully craft the intervention to the specific needs of the individual. So you may not, you're not necessarily reliant on the food pantry having the right combination of foods for someone's particular medical illness. You can provide that directly, so that can be an additional benefit of types of programs. And it can overcome some of these additional barriers by delivering it to people's home. This can be useful for people who aren't able to shop by providing fully prepared meals. This can overcome situations where there may be some inability to do the complex work of really following a complex medical regimen. So a lot of benefits there. So there are a lot of these interventions. They all have some evidence for them. They all, I think, are likely to work in certain circumstances. And so if we wanted to really have a comprehensive framework for what to do about food insecurity or what to do about situations where poor nutrition is going to impact health, we would like to have ideally a lot of options. We should have a variety of interventions that might work. These should vary probably in the cost and intensity of services so they can be used in the appropriate situations. They can serve as many people as possible when that will work, but we also have flexibility for situations when someone is not going to respond to sort of the average or the frontline intervention. And likely we'll need them to vary in who they work best for, just given the extreme complexity of people's situations, both medically, socially, psychologically, and so it will be nice to have a variety of things to choose from. We know from managing high blood pressure in the clinical setting, we don't have just one blood pressure pill that works for everyone. We have a lot of blood pressure medications that we can use in different settings, and that's why we're able to be successful in bringing that under control. And I think this is a type of situation where that would be nice to have as well. Well, how do we go from where we currently are to having this type of system? First, I think we really need to study and refine our current interventions. All of the types of interventions I've mentioned have promise and have some evidence to support them. However, we still don't know that we've made them as optimal as possible, and so I think there's more work that can be done to really optimize what we're currently doing. Can we refine these programs, make them have higher impacts on health, make them have the same impacts on health for lower cost? These are important questions that I think can be worked out, and I think the way to do this is to really use rigorous effectiveness research, so to incorporate things like randomization when we can, to use strong study designs for things that were planned for from the beginning to really maximize the amount of knowledge that we can pull out of programs when they're implemented. But also, I think beyond just sort of refining the programs individually, we're really going to need to move into the comparative effectiveness space. So we have more than one program that might address food insecurity. When do we use it for someone who's food insecure? And so I've put a schematic on the part of the slide here where you might be able to say, all right, you take someone with food insecurity. What do we try first? What do we try if it's not working? When do we know how to change? The problem, though, is that this is blank. It's not filled in because we don't always know what the right set of characteristics are that say, all right, start with this type of program, or, well, this is, we've given it a try, but it's not going to work, and so we need to move on to something else that we think will have a better chance. And so I really see the frontier of research in this realm, not only in sort of refining and really establishing the effectiveness of the current interventions, but in putting these together and coming up with a comprehensive way to assess for the needs that people have. Do they have food insecurity or not? Understand prognostic factors about what intervention is likely to work for the specific case of the individual, not just on average for a population, and understand situations where we might want to move from a lower cost, lower intensity, lower resource intervention to one that is maybe higher cost but offers more potential for benefit in a particular circumstance. So that's all I wanted to say for this, and I understand we're doing questions at the end, but thanks again, and this is a really exciting event. Glad to be a part of.
Thanks. I'm going to invite Anna from Project OpenHand to come on up. And we're going to take a quick jump over to California and then come back to Massachusetts.
Hi, everyone. Greetings from California. I am the Vice President of Programs for Project OpenHand, and I oversee all of the services that we provide to clients. So a little bit about Project OpenHand. Project OpenHand is a nutrition services agency that provides nutritious meals to seniors and adults with disabilities in Oakland and San Francisco. We started in 1985 during the height of the HIV/AIDS epidemic and have continued to grow since then and expanded our services to other chronic disease, to seniors and adults with disabilities as well. And we currently provide 2,500 meals a day through our grocery centers, our congregate sites, and our home delivered meal program. Today I'm going to talk a little bit about our latest work, which is our statewide pilot, which is providing medically tailored meal intervention throughout the state. I'll talk a little bit about how we're tracking and measuring the services being provided and the progress to date. So here are some healthcare trends we all know. Malnourishment is highly common in those being admitted to the hospital, and a significant portion of healthcare costs are spent on treating chronic conditions. We also know that chronic disease is not only on the rise, but greatly impacts seniors. And you've heard a lot about this growing evidence-based intervention model of medically tailored meals. And Project OpenHand and other providers have been building that evidence base. And here are some of the really exciting data points that have come out of some of that research. We know that we're able to reduce healthcare costs by up to 16%. We've reduced hospitalizations by 28%. Clients that are engaged in our intervention are also 23% more likely to be discharged to home and 50% more likely to increase their adherence to medications. And this is all data that's been grounded in 11 different research studies that have been done on medically tailored meal interventions. You've heard a lot about the Food is Medicine Coalition, and we are part of this nationwide coalition. And a lot of this research has been done by many of the different sister agencies as well as Project OpenHand. And in June of 2016, the California partners of the Food is Medicine Coalition started to strategize a little bit about how we can advocate for statewide funding for our medically tailored meal intervention. And we were really excited that in June of 2017, we were awarded $6 million for the intervention, and the pilot began earlier this year in April. Project OpenHand was awarded the contract from the Department of Healthcare Services in California, and it's the lead agency on the pilot. The pilot is also comprised of 5 other nutrition service providers, and we're located in the most heavily populated counties in California currently. It's a 3-year pilot, and during that time, we'll be evaluating the medically tailored meal intervention across 7 counties in California, which include San Francisco, Los Angeles, Alameda, Marin, San Mateo, Santa Clara, and San Diego. So the intervention itself, there we go. It's a 12-week intervention period, and during that duration, clients receive 100% of their daily nutrition, and it's delivered to their homes, and the diets themselves have been tailored by our registered dietitian teams to meet their medical needs. Additionally, our RDs provide 4 medical nutrition therapy sessions. 2 of those are done in person in the home, and 2 of those are over the phone. And the last piece of it is the information and referral services that we provide in case clients need additional support. I'm not going to get into these 3 next slides a little bit more. I'm happy to share or talk a little bit further about these, but it kind of goes into a little bit more detail on each of the elements of the intervention. So about the payment model, currently it's a fee for service with Department of Healthcare Services. It's a loaded rate that includes the cost of the medically tailored meals, the RD, MNT sessions that we're doing, as well as the case management support that the client services team provides. And as the program develops and grows, we are looking at other payment models, perhaps CPT codes for the MNT and the medically tailored meals. So a little bit about evaluation. While the full evaluation method is still in a design phase, we do know that the Department of Healthcare Services will be doing a match set evaluation. They'll create a control group by matching criteria and their claims data for CHF clients and those in the pilot, and a third party will be evaluating the information. So they'll likely be looking at readmission rates at 30 and 90 days. And another interesting piece of information that we're interested in perhaps looking at is our, based on some of the qualitative information we've gotten out of some of our previous research studies, which showed that the engagement piece was really valuable to the clients that were participating. So the RD visits, the wellness checks that the drivers provide, and also just that information and referral, those touch points being of great value. And I know some of the speakers spoke about the clients really feeling cared for, and I think that is something we're looking to potentially measure in a more formal way as well. So a little bit about progress to date. As I mentioned, the referral process began in April. Since then, all of the different partners have been working closely with their counties and the health plans within their respective counties, hospitals, care coordination teams to really try to increase engagement and enthusiasm around the project. And our goal is to have 1,000 patients by 2021. Some of the challenges and lessons thus far that we've learned and experienced. Enrollment's been much slower than we'd anticipated. We know that people are really excited about this, and just it's perhaps not top of mind for doctors or nurses or social workers that are at the point of discharge with a patient. So looking to create systems and additional outreach efforts to try to increase that just top of mind mentality that we need to continue the momentum on it. So creating an integrative system with flagging clients that, or patients that might be good candidates to be clients in this intervention. So looking to work on that a little bit more. And then also just, it's a new project and there are a lot of unknowns that we expected. So one of the things, for example, would be the 100% complete nutrition that we provide. We're basically providing enough food for a client to have 3 meals a day. And some of the early feedback that we've gotten from patients and participants is that perhaps that's a little bit too much from one provider. They feel like they don't get individual choice, perhaps, in getting all of the food from one entity. So figuring out ways to be able to ensure that food insecurity is not something that they're battling with, but also that they're not feeling burnt out by the services themselves. And the last challenge would be the exclusion criteria. It might be a little bit too rigid at this point. So right now, we're just continuing to evaluate clients that are enrolled and those clients that are excluded as a result of the criteria, and working with DHCS to see if perhaps we should loosen those requirements. And looking forward, just continuing to have collective discussions with health plans. There's a lot of enthusiasm and momentum in the food as medicine movement, as you've heard, so really want to continue to increase this. Also, standardizing these interventions is really important to make sure that all clients are receiving a similar level of care. And then continuing to address the other social determinants of health that these patients and participants may be experiencing, because nutrition isn't the only component that does destabilize their ability to maintain their health. And you can follow our progress and stay up to date and learn a little bit more on our website and follow our Twitter. Thank you so much.
And now I'm going to invite all of our physician panelists to come to the stage for our discussion on the physician's perspective on food as medicine.
I promise to speak more slowly for this part of the presentation. So, as you heard throughout the presentations today, we're making a lot of progress on integrating food as medicine into public and private health insurance systems. We certainly have much more work to do, and there are many challenges ahead of us. In order to successfully move forward, we certainly need the support and engagement of our healthcare providers and our healthcare institutions. Now, the great news is that we have some incredible leaders here in Massachusetts in the healthcare provider community. And today we're fortunate to have 3 of these amazing providers here with us today. So let me just briefly introduce them to you. First, we have Dr. Thea James, the Vice President of Mission and a Professor of Emergency Medicine at Boston Medical Center. We also have with us Dr. Kumara Siddhartha, the Chief Medical Officer at Cape Cod Hospital. And then finally, we have with us Dr. Eric Weil, a physician and internist and Chief Medical Officer at Partners Healthcare's Mass Health Accountable Care Organization. So welcome, all of you. Thank you so much for coming here today. So let me start off by just simply asking you the question, what drew you to get involved in food as a healthcare intervention?
I can take it.
Sure, start first.
So I've been in practice for nearly 25 years, back in India and here on Cape Cod together. And in my practice, I've always found, at least for the past 18 years, I've been practicing food is medicine practice. That's my prescription. So I've seen it work. I've seen it do a remarkable difference in addressing chronic diseases that are costing 86 cents out of every healthcare dollar that is being spent. So just seeing the difference it can make in patients is what really drew me into doing more of that.
Thank you.
So I can, I would say that it was a bit of an evolution for me. 20 years ago as a resident, I can remember working at a VA hospital, and there was a patient who didn't want to leave. And I said, why don't you want to leave the hospital? Who on earth would want to be in the hospital? And he looked at me and he goes, Doc, I get 3 square meals a day here. And I thought that was ridiculous. I said, so I was thinking to myself, food's a luxury and he's here for purely selfish reasons, which is not the case. But as a trainee, that's what I was thinking about. And then as I became an attending physician, I began to think of food as a poison. Patients would be admitted to the hospital because they had a dietary indiscretion. They had too much kielbasa, and they went into heart failure. They were a renal kidney patient. They ate too many bananas, and they developed an arrhythmia because they had too much potassium. They aspirated. And so for many, many years, I thought of food as not a good thing, but actually a bad thing. And in the past 3 or 4 years, and it only took me 20 years of being a doctor to begin to figure this stuff out, I began to pivot and realize that, food is actually curative. Food is something we love. Food is something that brings us joy and pleasure. And if used the right way, and if you ask the right questions, could be tremendously beneficial to your patients. And I began to experience that more with my own patients just by asking. Both on the inpatient side and the hospital on the outpatient side. And so as I've learned more about it and I've had the opportunity to see the types of important work that can be done, I've become increasingly more involved myself.
Oh, thank you.
Well, I'm an emergency medicine physician, and I always say that emergency medicine provides you with a unique glimpse into human nature, the human condition, and all of what constitutes life. And so you see what works, what doesn't work, but what you get to see pretty quickly is patterns. And you get to see cycles, and you get to see people who get, this sort of dubious distinction of being called something like a frequent flyer or whatever. And as physicians in medical school, they teach you how to address what's sitting in front of you, no matter if you see it every month, 12 months out of the year, but they don't teach you to understand the root cause of that. And so over time, I would start to ask patients and try to get to the root cause of why they were coming to the emergency department and inevitably being admitted 15, 20, 25 times a year, no exaggeration. And what I understood about human nature and the human condition and life for people is that when people have limited resources and they have to make really hard decisions between caring for their family, feeding their family, keeping the lights on, using what limited resources they have to pay a copay for a prescription or pay for transportation to get to a doctor's appointment, it's a no-brainer for them. Health and healthcare is always going to be secondary to people thriving and taking care, or surviving, really, not even thriving, to take care of their families. And so without paying attention to that and wondering about things like that, we actually, as physicians, wind up driving this. We are actually driving this because we will treat what's in front of us and we will send people right back to what's causing it. So, for example, if you have congestive heart failure and you need a diet that is low in salt, for example, and if you don't understand or know whether or not, or ask when you're doing discharge instructions and things like that, whether or not a person has access to healthy food, being able to afford it, or being in a place where it's in your neighborhood, or whether or not you're homeless and having to eat whatever's in the shelter. If you don't know these things, you will just inadvertently just drive what you're seeing in front of you. So when you're able to sort of pick up not only patterns, but understand what's driving those patterns, you start to get the big picture.
Oh, thank you. So you've all touched on this, but how do you specifically identify a need, food insecurity or another food nutrition need of your patients? Like, how does that happen in the emergency room or in your primary care visits?
The way I look at it is, I know the term food insecurity refers to food. I look at it as even a person who has chronic diseases in a malnutrition status where they may have conditions that are related to overweight and obesity like blood pressure, cholesterol, and not having access to nutritious food. They may have access to only a dollar menu, which is just calorically rich, but not having enough nutrition. So when we see even chronic diseases, that gives us a clue to look at, what kind of nutritional food are they getting, and are they not even getting the calories? Are they just getting only calories, not enough nutrition food that is actually going to turn around their health? So that's just looking at their disease patterns we can gauge. And we are, as a part of the ACO, in Mass Health ACO, we are beginning to actually screen them now as well for food insecurity.
You go first, I'll go second this time.
First of all, once again, I often will ask people whether they come in with whatever before, in doing the evaluation and understanding and taking the history. I always kind of want to make sure they have everything they need to not have whatever is happening happen again. So I'll just ask them, what would it take for this to never happen again? Many of my colleagues tell me they don't want to know the answer. So a lot of times that's why they don't ask. And that makes sense to me because they feel they can't do anything about it. But one of the things we are doing in our hospital at Boston Medical Center is for the past several months, we've been screening patients for social determinants of health in our ambulatory care clinics. And we've screened about 40,000 people at this point. So we screen them for food insecurity. and things like housing, education, income, employment, things like that. And we ask whether or not they want help with these things, and then we refer them, to the appropriate community-based organizations. It is in I would say, the referral piece is in a nascent stage. We've invested in a platform where it'll be more of a natural process, but right now people are getting screened, and the information goes into Epic, their electronic medical record, and their primary care doctor is able to see what people screened positive for and what they want help with.
Yeah, I would just reiterate some of the things that Thea just said. It's really hard to ask questions if you have to deal with the consequences of the answers. If you screen for falls and you don't have an intervention to help people with a fall, you don't just go, gee, be careful, right? And similarly, when you screen somebody for food insecurity, it's very disconcerting if the answer to the question is yes, and you've got nothing to do about it, or quite frankly, don't know how to do it. And so we'll talk about that a little bit. But yeah. I think that's one of the biggest barriers, number one. And then number two, how do we do it? We don't do it consistently. And I think that in general medicine and primary care, until very recently, this was one of the ad hoc additional questions that people asked if they happened to have the time to ask it in the 15 minutes that they're given the luxury of spending time with patients. And so it's very challenging to figure out how to prioritize all the things that need to be asked in this time of a normal visit. And that is beginning to change, and one of the ways that it is beginning to change is because of state requirements. So it's really powerful to have incentives that require you to do things. And Medicaid has created an incentive to screen for health-related social needs. And while not everybody's doing it, everybody's being forced to develop an infrastructure to make that happen right now. So to answer your question, it's not happening consistently. People aren't comfortable doing it yet, but because of the way that we are being moved by health policy and incentive, I anticipate that we'll be doing it much more consistently and frequently in the future.
There's one more thing I wanted to say is we also have a food pantry in our hospital.
Yeah.
And so our doctors can write prescriptions for food for people, just like a prescription for a medication. We can write that and people can go there and get food there. But for me, I think the next automatic question to that is, why are you food insecure? And integrating, operationalizing a mechanism within the food pantry that connects people to things like, for example, workforce development, where you can create networks of multi-sector workforce development partners, employers that you can, if people are food insecure because of income, that's an opportunity to connect them with jobs.
So what do you think, you mentioned a lot of things that are sort of barriers to more consistent screening, perhaps some of the challenges around referral sources, et cetera. What do you think would be most helpful to providers and to institutions to sort of further institutionalize the concept of screening and then effectively referring folks to food as medicine interventions?
I think what Eric said for sure. Now we've been.
So you're incentivized. That's why.
Definitely.
Yeah.
We're at great risk. We're incentivized because there's risk involved with that. We are being told to improve outcomes and decrease costs, and to prescriptively achieve that by focusing on social determinants of health. And we're given some help, with that to sort of create the infrastructure to do that. But I'm not so sure everybody, who's doing the work, clinicians, I don't know if that gets disseminated throughout an organization or not. The people who are in charge of things like that, like Eric, might be able to, operationalize that somehow. But I don't know if everyone understands it, all clinicians.
I would also add to that, saying that there are more than one piece. It's not just the incentives are key to drive physician behavior, absolutely. But I think physicians also don't feel, as was reported in some of the feedback, they don't feel confident about treating nutritional conditions, using nutrition as a tool. So that just goes back to how medical schools don't give enough nutrition teaching. Sure. That's an issue. So, but also healthcare is changing in a way that a physician seeing somebody in 15 minutes is not going to be able to fix all their issues, including social needs. So today, healthcare is a team sport on steroids. It needs to be a team sport on steroids, which means that if I'm the physician, I'm seeing a patient for 15 minutes, I need to have a nutritionist or a registered dietitian who I can refer the patient to, who is now linked up with a medically tailored meal provider, so that connection is going to happen. So as in that 20 minutes, I can evaluate the patient clinically, decide whether it's a diabetic geared nutrition plan, send them over there. I think that'll work. And also, the EMR, the electronic medical record, is a big piece. We are mandated to work with electronic medical records. And if this process and workflow is not integrated seamlessly into the electronic medical record, that's going to be a huge barrier in physicians taking this on. So the EMR providers, whether it's, they are all vendors, they are private vendors, they need to be somehow on board in this too, I think.
Yeah, all I'm going to say is repeat everything they said using different words. It's education, incentives, infrastructure, and resources, right? Those are the four things. And it's education for clinical teams, but also for patients, right? And making sure that that's kind of baked into everything, no pun intended. Number one, incentives, which we've already talked about. Infrastructure, if you don't, totally to your point, I'm very happy and very skilled at diagnosing hypertension and identifying the appropriate medications to treat hypertension. I rely on a team to help make sure that if I've diagnosed hypertension and I'm treating the patient, other people are assessing the other gaps that are going to prevent that hypertension from being appropriately managed. And in the idealized world of medicine now, there should be an entire team that wraps around a patient to allow that to happen. And we're at a critical point right now in developing those types of models. And what I would say to you all is that it is important to reinforce the value of team-based care in all of this work, because in the absence of that, you're going to have a lot of overwhelmed clinicians. And then obviously to have the resources in place so that when you identify the fall risk, you don't do just a tap on the shoulder and say best of luck, but actually have a place that you can hand off that patient to for the support that they need.
So, I mean, we are moving towards accountable care organizations in our mass health program. That will certainly restructure and create, hopefully, team approach to healthcare. How optimistic are you that we will be successful through ACOs at further integrating social determinants of health, food, nutrition interventions into our healthcare system? Do you think the resources are there to make that possible? You talked about resources. What do you think?
It's a definite maybe.
Maybe.
I think that there's a lot of different ways that healthcare in the United States can go over the next 5 to 10 years based on a wide variety of different policy-based decisions. I also think that the larger healthcare organizations will either be incented to move to models where they manage populations, or they will be incented to move in the exact opposite direction. And some of that, and it's all going to be watched very closely, is going to be predicated on whether or not models like accountable care organizations can demonstrate both financial success and improve clinical outcomes. If we can't show that, and there's not more of those models designed moving forward, the type of work that we've been talking about in this room will be challenging to continue.
Well, what about when you see the kind of outcomes that, Dr. Berkowitz and others talked about? Particularly, there's a lot of research on medically tailored meals, and you can see the improved health outcomes and really pretty immediate short-term cost savings. And do you think that success, if you will, in terms of the research endeavor will make a difference? And what do you think the barriers still are when, for example, there has been relatively strong body of research over the past few years that really support the idea of a medically tailored meal for that 5% of the Medicaid population that consume 50% of healthcare costs, that we can really bend the cost curve here and improve health outcomes? What would be the barriers to incorporating that within, for example, an ACO?
I'm an optimistic person, and I really am an optimistic person, but, and even answering that, I won't say but, and I'm around this, I'm slightly cautiously optimistic, and the reason is because the barriers that I am most concerned about is us getting in our own way, policies getting in our way, us constraining ourselves by what we actually think is possible to achieve. And sometimes you can be given every opportunity in the world to succeed, but if you don't broaden your mind around what's actually possible, if you think the same way you've always thought, and when it's time to create something, you create what you've always created, and then you're not more inclusive and bringing different people to the table to begin to discuss what actually is possible, then sometimes you won't get any place. And so we have to imagine, we have to not set low bars about what we think is possible, because they will become self-fulfilling prophecies, but set high bars. But yeah, we have to be more inclusive about, you know, who's bringing ideas to the table, who's being inclusive, including the voices of the people who we are trying to partner with and help, having those voices at the table as well. And again, as I said, policies. There are a lot of policies that create barriers for success. And so we have to be mindful of that as well.
I mean, programs like this and where we are today in this state plan, that is, you know, a ray of hope for me, and I'm optimistic when I see this and the events that's happening in California. But it is true that there is a lot more work needs to be done, a lot more coalitions and collaboration that needs to happen, because there are multiple players that need to be coming together, including CBOs. If I'm writing a prescription for a patient for a medication, if your doctor writes a prescription for you, it's just imagine how easily the system is set up for you to get that prescription, right? It goes electronically, it goes to the pharmacy. Every corner you turn around, there is a pharmacy that provides that to you, and it's paid for by your insurance. You may have a little copay, and then you're done. Now, that's the path of least resistance we have. And the question for us is, how do we turn this into that? How do we have systems in place, providers in place in every corner, right? The CVS on Rite Aid, right? And then you have a system in place where there's an electronic prescription that goes there, and a person can just pay a little copay, or in case of mass health, everything is covered, and take care of it. So we got to, and I love one of the quotes that I saw from a provider saying, we have to take the idea of food intervention out of the social determinants of health concept and just see it as an intervention, like a pill, like a procedure. It fixes issues. So how do we change? How do we create systems that are already in place? How can we model after the prescription systems that are there will help?
Yeah. I think the fact that we're having gatherings like this is a very positive sign, right? 10 years ago, I'd say that the number of people actively engaged in conversations like this was a fraction of what it is now.
We were at 30 people 5 years ago.
Right.
And
now we're
420 registrants last week, and we had to close registration. I mean,
right.
So if this is any indication,
right.
The idea of food as medicine is certainly catching on.
So now we need to proselytize, do more research,
so every
do
person
larger
here
studies, and have more outcomes.
Yeah, I agree. So I guess, is this a time that we can open it up to other people's questions from the audience? If you have questions, and perhaps bring some of the other speakers up as well for questions. Come up to the mic. Why don't you come up to the...
So there are mics right here in the two aisles. So if folks want to kind of go to the mics, and we'll take questions.
Thank you so much, by the way, for having this. This is incredible. These pilots and these interventions are terrific for the low-income individuals, but I'm wondering, there is a large contingency of people who they may not necessarily have the financial barrier or have food insecurity, but the issues are education and help with behavior change. And I'm wondering if there's any appetite to do interventions along those lines, and just what your thoughts would be on that. Thank you.
I mean, clearly, when you look at different social determinants of health, like somebody who has housing instability or homeless, this aligns, food insecurity aligns with that. So considering folks who have other housing need or other social determinants matches up with that, I think.
Yeah, I have a friend in the back of the room named Helen, who may be hiding back there. I don't know. There she is, who actually does cooking classes with her patients, where she actually brings them in and talks to them about how to produce. Tell me if I'm wrong. I'm wrong? I'm right. So I'm giving it. She's a great primary care physician, but what she does is she does cooking classes with her patients to teach them how to create healthy meals for themselves. And that's not necessarily just focused on an underserved population, that's focused on any. So there are people who are interested in doing that. And if there were more incentives for clinicians and other groups to do it, I think it's something that could be spread very broadly.
I'll also just say, and there is a fair amount of stuff that's already available for that. So the diabetes prevention program, which is an intensive lifestyle intervention, is a covered benefit for a large number of people, depending on their insurance, but a large number of people, they've had partnerships with YMCAs to make it available in the community. So that is out there. Medical nutrition therapy, which is consultation with a registered dietitian, nutritionist, is covered for Medicare, for example, 3 visits a year for people with certain conditions like diabetes and things like that. So there certainly are programs for people in this space beyond just ones that specifically focus on those with low income or food insecurity. But I think it's certainly the case that behavior change is hard and needs a lot of reinforcement. And as our medical system overall moves more from an acute care management thing to a chronic disease management and a prevention focus, I think we will need to redesign it to make these things kind of be a more seamless part of care in the way that we do office-based visits now.
And to the extent that these services are more embedded into our insurance systems in particular, we will see it cross all income levels. So. So I love that question. I love your feedback. I love your question. I love everything about this. But what we need to understand about the scope of this is that we're focusing on, if you imagine a Venn diagram, there's the food system and the healthcare system, and both are plagued with many, many, many problems that we're working on very hard, and different folks are working on them. Our Food Law and Policy Clinic is doing food system transformation work, and there's an entire coalition that we are linked to that has developed a Massachusetts food systems plan that is working on transforming the food system here in Massachusetts to do exactly what you want. We stand on the shoulders of all of that amazing work, for sure. But this is our opportunity to focus on that slice where the food system and the healthcare system are crossing right now. In the future, we hope that these circles merge together, right? But that's not where we are now. And the reality is we have to start here and expand out from there.
Great. Is this on? Thank you. And it is quite a growth here from even 3 years ago, which is the first time I'd attend. I'd also say I learned a ton of learning about even my own nutrition, which I thought I knew a lot about just by volunteering at community serving. So there's so much you can learn just by getting in there, and all the resources and education are available. So my question's on the screening and the metrics, and I don't know if it's who would answer, and there might be two different answers depending on the clinicians or outside. How standardized, or is it possible to standardize some of those screening questions, so like the depression screening, and is there a movement there to have those 5 questions that every clinician or provider could incorporate? And then the flip side, beyond the KPI of readmissions, and maybe it's Seth, what 2 or 3 metrics or dashboards for success could we have longitudinally to see effect? So it's a little bit of a 2-part question, but it's around metrics.
I know that in Massachusetts right now, at least in Eastern Mass, there's a coalition of hospitals and ACOs that are trying to standardize their questions around social determinants of health. The idea being that there's probably between 8 and 11 questions that you can ask in a standardized way in similar domains to obtain the type of information. And the hope would be that in the long run, if everybody's asking those questions, whether they're at Boston Medical Center or North Shore Medical Center or wherever, you'll be able to aggregate that information together to understand the landscape better. And there is national data on specific types of questions that should be asked. So I think that has been happening and will probably happen to a greater degree. Partners modeled a lot of their questions after what BMC put together, and I think a lot of other groups are doing that as well.
Right, and those were from some national models as well.
Right.
Yeah, I'd second that. So very possible to standardize. There are probably 3 to 4-ish sort of national instruments that are used nationally that are kind of competing, although they're somewhat similar. I don't think we know which one is going to win, so to speak, in the way that maybe the PHQ-9 won for depression screening, or but very possible to do this. The SIREN network at UCSF, SIREN, has a very nice table comparing the differences between some of the common social determinants of health / health-related social needs screeners, and so they put it up there. Ultimately, I think you'll probably get 1 or 2 that most people are using, and we'll filter down to that. But anyway, that's possible, and I think is coming. In terms of metrics, so I think the sort of utilization and cost metrics are obviously very important to some stakeholders. I think the other categories of things that are worth looking at, though, are one, what you might call clinical outcomes, and this may vary based on the clinical circumstance of someone. So hemoglobin A1C might be very useful for someone with diabetes, but is not useful for someone who doesn't have diabetes. Blood pressure control may be useful for people with high blood pressure, but not for there. But so I think we should always be keeping in mind some of these clinical metrics. And the third piece that I don't think has gotten sufficient attention, to the point that I don't even think there's a metric yet developed that works well for this, but I think really should, is I put in sort of the patient-reported outcome space. So I think when you do these programs, you realize above and beyond any change in healthcare costs or any change in a clinical biomarker, there's something else that's going on, an element of stabilization, hopefully an element of improving health-related quality of life, or reducing the stress over worrying where your next meal is coming from or something like that. And I think we need better ways to capture that and really count that as a true benefit of the program, because I think if we don't do that, then we're not going to account for everything these programs are doing for people, and we're going to undersell the value of the programs. I don't think there's not currently a metric for that in the sense of like a standardized instrument I can recommend right now. I think that's an active area that we need to be working on. We need to be incorporating feedback from participants in the program to do this and really get a good sense of when these programs are working, what are they doing for people, and how do we connect that to overall health and make it an outcome that's up there with any of the others that we've talked about.
Well, I kind of disagree with what you just said about, the division between health and food, or medicine and food, because we're such in a crisis, and we're going to be in further crisis with the obesity, that I think you have to have some anger here, because what you haven't talked about, you haven't mentioned sugar. You haven't mentioned the food industries. You haven't mentioned that a lot of kids or parents go to bodegas or other places. We should ban sugar within 15 feet of a cash register. that would be an interesting case to take. But really, think of the money that you deal with the food industries. I mean, you have a lot of people come to you with pharmacies, but food industries are placing food in supermarkets. You know about when you go to a supermarket and you see a red pepper, you only see red peppers in the vegetable market. Where do you see chips? You see chips 6 places in the supermarket because the food industry has paid the grocery to put those chips there. So I think you have to, I understand that you need to be focused and that's important, but I also think that you have to broaden, and everybody else here also has to be broadened to the fact that it's money, and money is the only thing that's going to get, like you said, things to change, and leaderships, because they're getting paid, and the leaders, political leaders especially, are getting supported by the food industries who don't want to change the way that we're feeding America. And
just to say, you know, I completely agree with what you're saying. We, for example, have a whole sugar consumption initiative. It's a 3-year project across the country, trying to work in cities and towns to reduce sugar consumption, all of the kinds of things you're talking about. So I think what Sarah was trying to say, and I think what we're saying here today, is we are just focusing on food as medicine. And if you go onto our website, for example, you will see the range of 10 or 15 kinds of projects and programs that we're working on, and we certainly did not cover even a small portion of them here tonight.
And we certainly won't miss an opportunity to fold this work in with that. You know, that would be silly. That would be ludicrous. And, you know, there is a lot of anger here. But the thing about the healthcare system is also that it's so complicated. We need to fix what we can fix in the spaces that we can fix them, and do it well and do it right. If we miss the boat, we're, you know, the cat is out of the bag in terms of what are we all going to do about social determinants of health, and we're all kind of trying to figure it out. And I think that we could go in right directions and wrong directions. And I'd be curious about what you all think about that too.
I wanted to say that's a very good point you're making, and I think when we look at system status quo that is causing, you know, burden of disease, one way to look at it is, if we need to change status quo, we need to create systems, like what we're talking about, that are easily accessible, more affordable, and that alternatives, if they can be presented in a way through policy, can be the path of least resistance for that person to go. So like if you're on a highway, and if fast food is the easiest accessible thing, and that is $1, that's what we're going to go. And how can we create systems that is going to trump that is what I would like to think about and say. And I think working with partners will help to reach that in policy, working with team approach in healthcare, like working with dietitians, working with community-based organizations is key. We have like our partner, Sustainable Cape, is there, sitting there, Francie Randolph. I think all of our programs need to consider how we can use team approach. I think that's the kind of emphasis I'm trying to make here.
We have to move through questions relatively quickly, so let's go.
I think you've identified a big blind spot. And thank you. That's definitely something we need to think more about.
Yeah, I would just say I'm not aware of any work that's being done, but I think you're absolutely right that that's an avenue we should focus on.
Hi. So I run a community-based organization that provides hunger assistance in the northeastern corner of the state. I've listened to Seth now maybe four times over the last several years at FRAC and some of the other local conferences. And I do have one comment from your surveying. I think one, the surveying, particularly the provider physician surveys that you found echoed what FRAC found nationally in their surveys of physicians where they don't have enough information, it's not front of mind, and they don't know what to do. As you all said, they don't know what to do with the yes. If somebody says, yes, I can't, access food. And I think that it's really important. The other thing that struck me in your surveys and was one that there were only 12 users of the services who were surveyed. So I'd hope that there's more opportunity to speak with people who are relying on these kinds of programs. But even in those, the strong themes that you heard were, that they themselves, without prompting, realize that eating healthy food leads to better health. So that it's not completely that they don't know that. It's the access. But the other piece is the care and the connectedness that you had mentioned. And so we've actually just started partnering. We're launching a program next month with our largest regional pediatric practice. And they, for 9 months, were using a social determinants survey for all of their patients. So over 10,000 surveys completed in 9 months. Not a single one answered positively for 5 different social determinants. We took a 30-day period with them and implemented a food insecurity screening, which used the hunger vital signs followed by a bunch of follow-up questions. With 50-something respondents, 17 reported positive for food insecurity in 30 days. So I think the key is, I think about the domestic violence screening and how you have a medical assistant who's typing on a computer and asks you, do you feel safe at home? And they may or may not make eye contact. And then a physician might ask you that, and they may or may not make eye contact. And I think about those 9,000 or 10,000 people who answered no because there was no eye contact and no connection. And so I think that the training and the physical space and the interaction that follows when you're asking this is really important. And I worry how many times I heard each of you physicians say, you have 15 minutes with a patient. And I thought, oh, so I guess I'm not the only patient who only got 15 minutes with my doctor. If that's the standard for practice that you all are saying you have to uphold, then I challenge you as physicians to say we cannot practice that way. I won't get into what y'all are billing for that 15 minutes, but that maybe you have to take a half an hour and you have to make eye contact and you have to make sure that you can have a conversation and build that trust. Otherwise, your patients are not going to respond positively. So I just want to make a strong comment on that. Then on the flip side, my question, the other piece in your survey of the payers was that there was no indication that any of them had any inclination to change, like to pay for any of this. I forget exactly how it was worded. And so I think about what are the funding sources. We're, as a community-based organization, as a nonprofit, I'm providing the actual intervention, and to go through the hoops of becoming a provider to be paid through the health insurance companies, but then to know how much my pediatric office is reimbursed for the survey, just to implement a survey that no one answered positively to. I just think about the sustainability, and I just wonder if any of you really have some concrete ideas of the direction of how you think you are going to move the needle to actually put resources behind this approach.
You bring up some very good points. I would say that in the shift towards accountable care organizations that is happening, there are operational processes that allows for some of the things that you mentioned lacking. For example, in our ACO, yes, the doctors have limited amount of time, and as I said, the way healthcare is that, and it's a good way to look at it, is that a physician, one person cannot fix it all. So in that 15 minutes. So what we have is in this ACO model, we have hired care navigators who live in the community, who know the issues because they themselves have been in suffering with those issues. So we have hired care navigators who actually help patients find you, right, and connect you with the physician. So that kind of a system change, I think it's being facilitated by the ACOs, where physicians can team up with other CBOs through these care navigators to make that happen. With regard to that partnership and how and with regard to your question about surveys and how the funding resources shape up between the partners, that is still, this is all new what we are doing now. So that's still not there's no framework for that yet, I think, at this point.
Yeah, but I think you're right, and I think a real issue with some of the linkage type interventions where the screening happens in the healthcare system and people get referred into community resources is having the capacity and the volume to deliver that intervention outside the healthcare system. It's obviously not sustainable for all the resources of that program to stay within the healthcare system when the actual content of the intervention is being delivered outside the healthcare system. And so I think for that to work, there need to be the financial systems to make that possible. I think the California Medicaid pilot makes that work. Like the food as medicine providers there get some money to deliver the intervention. It's not just case finding in the hospital and then done there. Similarly, in some of the insurance contracts that Community Servings has, they get paid for that. And so I think these things have to come together. I think you're absolutely right that this is so early. There's no sort of standard for it, and it's a very ad hoc and a big mix of things. But yeah, I mean, the arithmetic is pretty simple. If you're not putting dollars into providing the intervention, people aren't going to provide the intervention. So
This is, sorry.
I just want to say, my fear is then it would discourage physicians from getting involved because there are only 5 dots on that map where they could actually refer someone. So I just worry about perpetuating itself.
Thank you.
Changing my question a little bit on your answer. So I appreciate that you guys are up there at the leading edge of your field trying to change food. That's why we're all here. This side of you could attack the way you're taking it from the top of acute and chronic and expensive. But of course, this is a lifetime of things that led up to this event. Like Eric said, you don't fall because your knee's necessarily blown out. It's a lifetime of lack of balance, coordination, and exercise that led to that point. So my background is in data and analytics and engineering, and probably you, Seth, but for anyone who wants to answer, what data set or data point or like outside the box stream of information changes the whole perspective on this conversation that changes this field in 10 years?
So I mean, I think you've hit on a couple points, and I really like the Chilpy sort of pyramid where it points out there are some aspects of prevention, getting to the points where you're talking about how do we stop this from happening. There are other aspects of acute treatment. We have people who this lifetime of insults has occurred to, and they're in front of us right now, and we need to do something. And I think those are both totally relevant things that we need to be working on in parallel. I do think incorporating more data about social determinants is really useful. So I think from standard kind of clinical record EHRs, we're now doing some individual level screening, and so that data will be incorporated. And I actually think the fact that you can screen 10,000 people, hopefully with better screening procedures that generate true responses and not just page after page of false negatives, will be useful. And I think you'll be able to apply some advanced analytics to having that sort of social determinant of health-related social need information crossed with some of the clinical metrics, crossed with utilization outcomes and things like that. I also think some of the geographic information system technology where we can combine things like American Community Survey data from the census, data from the USDA on sort of food access, like the Food Access Research Atlas and things like that, and really put all of these things together and have kind of true multi-level pictures, so both area level and individual level information across different domains, health-related social needs, clinical needs, community characteristics, crime, violence, transportation, environmental characteristics, all these things. I think we really do have a lot of potential to merge all of these things and then analyze them and find patterns that we haven't found. So I think that's very exciting for finding things out, but I also think there's still going to be a lot of shoe leather on the ground work of building personal connections, working with people, understanding the complexity of their social circumstances, understanding the complexity of the regulatory environments that human services organizations are working in, that healthcare organizations are working in, being able to share information across. And so, so there's a lot that's going to be done. But I do think the advanced analytics will play a big role in helping some of these issues.
You know, and Seth, I'm speaking as a non-researcher, but it would strike me that pediatrics is a huge opportunity in terms of following people longitudinally for periods of time. We know that childhood trauma results in increased frequency of substance use disorder and behavioral health illness in adults. There are probably characteristics of family dynamics that impact on children that will have impacts on healthy lifestyle and eating as adults. Of course, that's something that's not always appealing to insurers because the time horizon on improving the outcomes is decades. But I would imagine that that's an important area to follow in a longitudinal way as well.
So last question really quickly, because we have bartenders waiting and waiters waiting to serve food, and a quick closing remark. So, okay.
Tulane University, their School of Medicine has a Culinary Matters program, so they actually, as part of their kind of standard curriculum that all medical students get, have both talking about what healthy food consists of, but also how do you teach people to prepare healthy food and those kinds of things. So to my knowledge, that's been one of the sort of leaders in including this in the medical education curriculum.
And that curriculum is now taught in 20 or 30 different medical schools. It's been licensed to other medical schools. I'm going to wrap it up because I think we all deserve to have a nice cold beverage. Coming in to close it out, I'm David Waters. I'm the CEO of Community Servings, and it is so heartening to see you all here. I think we all knew two things when we walked in the room. We knew that food is a basic human right. And in a country like this, with the resources America has, no one should be hungry. But we also know the basic fact that what we eat impacts both our health and our health outcomes. What I want to have you take away, though, because we're trying to create a buzz here, and having you in the room and seeing the sheer number of people is so important. But the thing I want to have you take away is the number 16% cost savings if you're providing medically tailored meals to a critically ill population. The research that Dr. Berkowitz did with Community Servings and others around the country showed a 16% cost savings on their healthcare costs. Less hospitalizations, less ER visits, less ambulance usage. If we get that message out to the healthcare world, those who do it for the moral right of feeding the sick will respond, but those who do it for dollars and cents will also respond. And that's the magic of what we're doing, and that's the message we have to all get out, because there are resources in this country to pay for this, and it's not a pipe dream. That's what we're going to make happen, but we need everyone, that team approach, to make it all happen. With that, I want to say thank you for coming, and I really want to just pause to say, first of all, thanks to our presenters and our speakers. They're such dear friends and such incredible experts, so thank you very much. And I also want to remind everybody that an event like this and this kind of amazing research that Sarah and Jean presented doesn't happen without far-sighted generous philanthropic supporters through the Blue Cross Blue Shield Foundation of Massachusetts and DentaQuest Foundation. We are so proud to partner with you. I know Chilpi feels the same way. I've been in this nutrition desert for 30 years, and to see that this is not a mirage, that you are all here today, 6 years after we started this, is so heartening. And do not get discouraged, because this is the inflection point for food as medicine, and we will make it happen. It's just within our reach, but we need more people echoing that 16% number. And with that, I hope you'll stay for a drink. For those of you who define yourself as a young professional in the room, we also have a second reception just to carry this energy forward. Cambridge Common down the street. We'd love to have you join us there, or stay tonight here for a glass of wine or a beverage. Thank you.
That was a pleasure. Thank you.